We're talking today about the molecular driver EGFR, which is the first driver that was identified at least as having a relevant target that was effective in treating it, with initially first generation EGFR inhibitors that we don't tend to use as commonly now. And over the past 15 years or so, we've made major advances, still some open questions. And let's just start with the basic question today of a patient who you send off molecular testing for, and you get back the result that they have a common activating mutation, exon 19, which is the most common, and they have metastatic disease to the liver and the left adrenal gland. They have a good performance status and no brain metastases. You have a range of options now, multiple EGFR inhibitors and potentially combinations. What is your recommendation for upfront treatment of your basic strike down the middle EGFR mutation positive patient? Carolyn, I'll start with you.
Yes, so based on the data from the FLORA study, they have demonstrated that osimertinib is superior in terms of both progression-free survival and now overall survival.
And that was already arguably a standard of care before the overall survival. Now with the recently reported, and this is just going back to, I think, late September when they reported the overall survival, does that, in your mind, Heather, clinch it clearly? Or what about the people, docs or patients out there, who like the comfort of having a potential sequence of EGFR inhibitors? So does that hold any water for you as an option?
Well, I think if we could know which patients are going to develop T790M as their resistance mechanism and go on to osimertinib and do well, then absolutely I buy that argument. The problem is we don't know. And until such time as we're able to figure out, based on maybe co-mutations or other things that we can predict, who's going to get on to develop T790M and who's going to have some other problem, I think we can't really predict that. And so that's what FLORA told us, is that if you look at the whole population, starting with osimertinib is a higher probability of getting someone to a longer time of living, not just living on their TKI, but living overall. And so that's hard data to argue against, at least in the United States, where we have the agent available. I think globally, there's a lot more discussion because of cost differences in availability and emerging data that if you give an EGFR TKI plus bevacizumab, or even an EGFR TKI plus chemo, you can maybe prolong the benefit of the first or second generation drug, still relying on the fact that half the time you'll get T790M as your resistance mechanism and then could go on to osimertinib. So I don't think the argument's completely gone, but at least in my practice, if we identify an EGFR mutation, such as EGFR exon 19, we do start with osimertinib, carefully monitoring heart toxicity and other aspects that could come up.
So just because I think it's helpful to define things a little bit for the audience, first generation EGFR inhibitors are gefitinib, Iressa, and Tarceva, erlotinib. And those are widely available in Asia. Icotinib's another one, but we don't have that and don't really need it. How many could you use? And then second generation agents that are FDA approved and available include dacomitinib and afatinib that may be a little more effective, but tend to also have, then first generation agents tend to have some toxicity issues. Afatinib's known as Gilitrif and dacomitinib is Exempro. I don't remember. I don't prescribe it often. So, and then osimertinib that we've discussed quite a bit is Tagrisso, that people may well be familiar with. And this trial FLORA handily demonstrated a better result with Tagrisso beating the first gen agents for both time before progression and switching to something else and survival.